All right, so I'm going to talk about some new devices to supplement plating and why to use them and when to use them. So let's get to it. Those are my disclosures, none of which have any impact on this talk. So these are the areas that we're traditionally plating a lot. And we're moving again, I think in the trauma world towards doing a lot more nailing of these type of injuries. But if we are plating, these are sort of the issues. So you tend to, in the proximal tibia, distal femur, and proximal femur and proximal humerus, you tend to hang your articular work off of a laterally based plate. And so there are some mechanical disadvantages to that. And that's sort of what I'll go through here. So these are just some examples of those mechanical disadvantages. So this varus malunion, non-union of this periprosthetic femur, which required a revision below. This patient, again, varus collapse, hanging the articular block of the proximal tibia off of a laterally based locking plate. And of course, we all know in the proximal humerus, these varus injuries can continue to go into varus, and your locking screws, particularly at the top, as it settles, will have a tendency to cut out far too often. So the current solutions, the first thing was the blade plate, then followed to the locking plate. And then in some situations, we'll go to dual plating. There's a lot more nail plate combos that are going on. Just periarticular nailing in general has really taken off. And then this talk is about supplementing your plating if you want to do a plate and you don't feel that the other options are possible in the particular case that you're looking at. So again, a couple ways you could potentially supplement. So nitinol cage, fibular struts, and calcium phosphate type cements seen there. But this is sort of how I got interested in it. We'll just do a case-based example, and this is we've already heard mention from Dr. Moon and Dr. Marasek about a lot of use of fibular allograft struts for strength, and so this is one other way to use them. So a 70-year-old male had this plateau here, and I thought because of the tubercle fragment being separate, it was a little bit be a little bit of a challenging nail. Although it's possible that you could nail, that would be up for debate, as there's not a lot of articular injury there. So the patient got placed into sort of a funky external fixator, and had the soft tissue injury there is seen on the medial side of the tibia, and the lateral side pristine. So it'd be a nice place to plate laterally, but there's so much comminution. Again, you worry about that malunion hanging the whole articular block off of your laterally based plate. So again, this is just utilizing a fibular strut through the fracture, making a pathway for it, and then perking a plate. Oh, excuse me. So, there we go. So fibular strut for your medial column support, then perking your laterally based plate, and then getting your tubercle reduced and some screws. And you end up with this triangular kind of construct where you have a laterally based plate, something medial, and then rafting screws to complete the triangle, allowing, hopefully preventing varus collapse. And so that's what it looks like when you're done. So all the work is on the lateral side, and you can avoid that plating of the medial, making an incision to plate the medial side. And here's sort of another example of how I've used fibular struts just in periprosthetic. You could argue that you could do a nail with this with the better nails now with a cluster of distal screws, and that's an open box knee. But this patient, again, fibular strut, got a nail, slight golf club deformity, but ultimately went on to heal fine there. So this is getting to some newer devices now that I'm using to do very similar things, and I think in a much easier way. The fibula has to be fashioned by you with a saw and fit in. And also it has to go in through the fracture, and it's difficult to insert any other way. You can ream and put the fibula in like you would a nail, but it can be challenging to get it in, and you're making a hole in the bone. So this device is a light cured epoxy in a Dacron balloon that essentially expands to meet the canal and metaphyseal width. And there's a bunch of different sizes of these. And they go in, and it's kind of cool in the operating room because you get a nice light show. Dr. Moon, I know you love that right picture. And you can put these in through some super small incisions, and sort of, so this is a standalone case, just to show how small those incisions can be on the shoulder using this epoxy cured essentially nail that expands within the canal to fix a proximal humerus in a 96-year-old. But onto the cases. So this is kind of trying to think a little bit outside the box to figure out whether or not to fix this bicondylar plateau in a frail, homeless chain smoker who fell 3 weeks ago, but does walk. So here are images. It doesn't seem like too much going on there. And we definitely considered treating her non-operatively, but she couldn't walk, and she really wanted us to let her weight bear her so that she could take care of herself, when given her difficult social situation. So let's see if this will play here. Yeah, so she had that medial column injury there, and then she had this lateral column injury. So mostly all just depression, and I think we can skip that. So this is what I did all through very percutaneous, maybe 3 or 4 5mm incisions. So first I put a guide wire up to essentially place a strut across that medial column. So that's a guide wire placed right into that posterior medial area, and then a reamer to create a path for the balloon. And this is the balloon that goes in and supports the medial column, right into the spot where she had the starting to have that shear injury of the posterior medial column. And then introduced through a separate small incision a fracture balloon, and utilizing a balloon, we're able to reduce her plateau to pretty close to anatomic. And then the key here is to fixate that small depressed fragment with these K-wires, which are, you have to sort of place right above the balloon, try not to pop the balloon, and then remove that balloon, and then insert your calcium phosphate cement underneath of it and place it with additional headless compression screws, sort of as rebar. But I think most of the strength here is from the epoxy and from the calcium phosphate cement. And she was able to walk on this with no pain, and less chance of having an infection with a small approach that's required for this. Another sort of representative case, 74-year-old female, difficult patient, Jehovah's Witness, BMI 62, had an open distal femur fracture. She was a non-smoker but diabetic. So challenging patient, had this distal femur. And again, you could argue it's possible to nail this. And it was pretty distal, and be interested to see if anybody would, if the panel would attempt a nail on this. I felt it was fairly distal, did have intra-articular split right where the nail would go in. Really no bone at all. You can see on the 3D recon on the right-hand side, on the lateral, that you can pretty much see through her femur because there's no bone. And I just put that other image in there to show how big her leg is. So she's a very, very large lady. So I put her joint back together, and I put some wires through the notch because her bone was so bad that nothing was holding except for that notch bone. But we was able to get a anatomic reduction of the joint, which was a fairly simple thing. And I put a guide wire up through a very small 5mm incision for the Illuminos device. And then that's the Illuminos device deployed within the epoxy device deployed within the canal, filling it and giving it a lot of extra, well, not bone stock, but a lot of extra strength for placing a percutaneous laterally based plate. And again, I did actually put a screw intentionally through her notch because that was the only place where there was some reasonable bone there for to hold the articular reduction. And then, so that's how she ended up. The one nice thing is the intramedullary device really holds the reduction during the percutaneous plating almost perfectly. So you don't have to, so you're really just using the percutaneous plating portion as like a sawbones exercise. And that's it. And thank you very much.
How this thing really intrigues me. How do you kind of control, I guess, how far the balloon goes? Is it sort of like, because it, couldn't quite tell on your things, but as you insert, does the inserter have a certain set length and that's the length of the balloon, or?
So I think of it as pretty much as putting in a nail, but you can use much smaller instruments because the balloon starts out as, I believe, about 6 or 7 millimeters. So what I use is you can use a guide wire off of like a large cannulated screw set and a reamer. So like off of a standard 6.5, 7.3 set, or off of a large AccuTrack set. You use a guide wire and the drill, the cannulated drill, to make a very small hole somewhere. Then you introduce a fixed length balloon. So there's a number of different sizes of that balloon in length and diameter as to how big it'll get. So then you insert your balloon and you check it. And then what you want to do is you want to and then you take a syringe full of liquid epoxy, and you really need to expand that balloon as much as possible. The time when you have a risk of a higher failure risk is if you don't get good expansion of the balloon, because it ends up star shaped if you don't expand it rather than cylindrical. And they found that that's much weaker. So you really do want to try to get as much of the liquid in as possible. Then once and then at that point you have to check it. You have to make sure everything's perfect, because once it hardens, it's in there forever, pretty much. So then once you're happy that it's perfect, then you put in your light source, and for a set amount of time, it's anywhere from about, probably, depending on the monomer, maybe 10 to 15 minutes, 8 to 15 minutes, something like that, while it hardens. And then they have a specialized cutter to cut it. If you need a shorter balloon, there is a technique to make the balloon shorter, and you should ask the rep on how to do that. That's the basic technique. After it's hard, you can drill through it with pretty much anything. It's like an infinite hole intramedullary nail.
So when you're putting it in, there'll be potentially some balloon and epoxy, it's like sticking out, but you can just cut it off.
Yeah, so you have to. I don't know if it's really in the technique guide, but if you need to shorten it, then you use a device to essentially occlude the portion of the balloon that you want to the amount that you want to shorten, so it doesn't expand when you put in the liquid.
Okay.
So you can kind of customize it shorter. You can't customize it longer. You'll know there's a radiographic marker for the full length of the balloon, so you know when it's fully inserted, if you have like the optimal length, and then you can and then the cutter is fairly easy at the end. It just cuts flush with that marker. So I guess my point is the only difficulty is shortening it, but it's possible. You can do it.
Intriguing. I'm fascinated, and those cases are the kind of things we do see a lot of, and that distal femur, I probably would have done a nail plate combo, but this idea of using the Illuminos, making that basic same biomechanical construct, but a lot easier mousetrap, I guess is the way to put it, right?
Definitely. And I mean, my whole thing, and I know you treat a lot of geriatric fractures as well. The whole thing is getting these folks weight bearing, and not just letting them weight bear, but actually having them weight bear because they're not hurting. And I feel that this this definitely has potential for allowing that. And I know all the stuff we're doing of trying to use more nails, nail plate combos, dual plating is all trying to get these folks to weight bear. And I found these people can weight bear. That, of course, the downside, like anything in medicine, there's a downside. The downside would be, I would imagine this would be fairly challenging to get out. And I haven't had to take one out yet.
Yeah, that's the one thing that I'm a little bit concerned about, is if something happens and you need to take it out, it looks like more than a little challenge to get it out.
Yeah. I did have one in a very challenging patient for a periprosthetic tibia break.
Mhm.
But when I revised the plating on that patient, it was still good to have it because it's, even though it was broken at the fracture and I had to rely on my plates for stability at the fracture, it still gave me excellent purchase with my screws within those segments. And the patient did fine.
Okay, cool. Well, that is fascinating.